Welcome back to the Deep Dive. It is great to have you with us again. Today we are zooming in on a specific piece of human anatomy. It's surprisingly small. It weighs only about 15 to 20 grams, which is, I mean, it's nothing when you think about the rest of the body.
Tiny.
It sits quietly at the base of your neck, shaped like a little butterfly, just sort of wrapping itself around your windpipe.
All right.
But despite its size, the sheer amount of chaos this little organ can cause if things go sideways is staggering. We are talking, of course, about the thyroid gland.
It is small, but it is incredibly mighty. It really is the engine room. And,
Right.
Usually when we talk about the thyroid, we're discussing the hormonal side of things.
Metabolism, feeling tired, all of that.
Exactly. Gaining weight, the engine running too hot or too cold, hyperthyroidism, hypothyroidism. That's, the bread and butter of endocrinology. But today, we are shifting gears completely.
We're not talking about hormones.
Not at all. We are looking at the darker side of this butterfly. We are looking at what happens when the cellular machinery inside that gland decides to stop following the rules. We are talking about thyroid malignancies.
The C word, cancer. It's a heavy word. And, in most contexts, it just sucks all the air out of the room.
It really does.
But what I found so fascinating about the research stack we're diving into today, the articles, the clinical guidelines, is that thyroid cancer isn't just one monolithic thing. It is not a single enemy.
No.
It's a complex puzzle. And honestly, some of the pieces don't fit together the way you'd expect them to based on what we know about other cancers. We are going to specifically shine a spotlight on the big one, papillary thyroid carcinoma.
Exactly. And the reason we are focusing so heavily on papillary carcinoma is that biologically and clinically, it is the dominant player in this story.
It's the one most people get.
By far. So if we're trying to give you the pearls, those high-yield nuggets of information that specialists and medical students have to burn into their brains, we have to start there.
Right.
But it's not just about memorizing facts for a test. It's about understanding a very specific biological narrative. This cancer tells a story about how our cells work, how they break, and surprisingly, how well we can fix them.
So let's establish the mission for this deep dive, because looking at these papers, we could get lost in the weeds of molecular genetics and gene mutations for hours. What's the goal here?
We could easily get lost, but we won't. Our mission is to decode the diagnosis and treatment of these cancers in a way that's practical. We want to take you from the high-level classification identifying the bad actors down to the microscopic level.
Okay.
And that's where things get surprisingly and weirdly poetic.
I'm intrigued.
And finally, we want to explain a paradox that really stood out to me in the literature. Why having cancer spread to your lymph nodes, which sounds like a death sentence in almost any other context,
But absolutely.
isn't always the disaster you might think it is here.
I love that. We are essentially giving the listener the knowledge of a specialist without the crushing weight of medical school tuition.
Or the sleepless nights of residency.
Right. But before we get into the nitty-gritty, tell me, why does this specific topic matter so much? Why is there so much emphasis in the medical community on classifying these things so precisely?
That is a crucial question to start with. Because in many areas of medicine, you treat the symptom or you treat the location.
Sure, if you have a bacterial pneumonia, you treat the lungs. If you have a fracture, you fix the bone.
Precisely. But with thyroid cancer, the management is strictly, and I mean strictly, dictated by the histological type.
Histological type, let's define that immediately for everyone. We're talking about what the cells actually look like under a microscope, right? The pattern.
Precisely. Histology is the study of tissues. You cannot treat a patient until you know exactly which cells are misbehaving. The biological behavior changes completely based on the cell of origin.
So two lumps could look the same from the outside?
They could look identical to the naked eye, or even on an ultrasound, but under the microscope, one is a slow-moving turtle and the other is a sprinting cheetah. And, as we touched on, papillary carcinoma alone accounts for the vast majority of these cases. So if you understand papillary carcinoma, you essentially understand the bulk of thyroid oncology.
Okay, let's unpack this. If the treatment depends on the classification, we need to know who the players are. It seems like there's a cast of characters here, almost like a crime drama.
Or a dysfunctional family. That's a great way to think about it.
So can you break down the main types of thyroid malignancies for us?
We can absolutely think of them as characters in a drama, divided by their lineage, where they come from. The thyroid gland is mostly made up of follicular cells.
These are the workers.
These are the workers that produce the thyroid hormone. So most cancers come from these workers. First, you have the differentiated thyroid cancers.
Differentiated.
The word differentiated is key. It just means the cancer cells still sort of look and act like normal thyroid cells. They haven't totally forgotten where they came from.
So they're the copycats.
Yeah.
They're bad. They're cancer.
Yeah.
But they still resemble the original butterfly cells.
In a way, yes. They are well differentiated. This group includes papillary carcinoma, our star today, and its cousin, follicular carcinoma. They're the wolf in sheep's clothing.
Okay.
They look like thyroid cells. They sometimes even try to make hormone-like thyroid cells, but they have bad intentions.
Okay, so that's group one, the copycats.
Hmm.
Who else is on the stage?
Then you have a unique character called medullary thyroid carcinoma. This one is really interesting because it doesn't arise from the main thyroid cells, the follicular cells.
It's from somewhere else.
It comes from a totally different neighbor living in the same house, the parafollicular C cells.
Parafollicular C cells. I remember reading about these. Those are the ones involved with calcium regulation, right? They produce calcitonin.
Spot on. They're neuroendocrine cells.
No.
So biologically, medullary carcinoma is a completely different lineage. It's like finding a stranger in your house who doesn't belong to the family but has decided to set up shop.
A completely different problem to solve.
A completely different playbook.
And then finally, we have the one that sounded the most terrifying in the notes, the anaplastic carcinoma.
Yes, the true villain of the story. Anaplastic basically means undifferentiated. These cells have mutated so aggressively that they have reverted to a primitive state.
So they don't look like thyroid cells at all anymore.
Nothing like them. They are just raw, aggressive, dividing chaos. It's messy, it doesn't play by the rules, and it grows incredibly fast.
So we have the differentiated group, papillary and follicular, then the medullary outsider, and finally the anaplastic villain. How do these behave differently regarding the patient's future? I assume the villain is the worst news.
It is, unequivocally.
Yeah.
When we look at the spectrum of behavior or prognosis, anaplastic carcinoma is the most aggressive and carries the worst prognosis.
How bad is bad?
It's often considered a medical emergency because it can grow visibly from day to day, compressing the airway.
Wow.
On the other end of the spectrum, you have papillary carcinoma, the focus of our deep dive today. It is the most common, but thankfully it also has the best prognosis.
That is a massive relief. So the one that most people get is also the one that is most treatable. That feels like a rare stroke of luck in the world of oncology.
It really is, and that's a general rule of thumb here. Most thyroid cancers actually have a good prognosis. Anaplastic is the dangerous exception, but it is rare.
Right.
But for the vast majority of patients, those with the differentiated types, the outlook is quite positive. It's a cancer you can live with and often live after.
Now, here is where it gets really interesting to me. We talked about these cancers traveling, metastasis. If a cancer starts in the neck, it doesn't always stay there. But the sources suggest they use different getaway vehicles. How does that work?
This is one of those classic medical distinctions that doctors use to solve the puzzle. Knowing how the cancer spreads helps doctors identify what it is. It's like forensic profiling.
Okay.
Papillary carcinoma, our main character, prefers the lymphatic system.
The lymph nodes.
Oh.
That highway of immune vessels running through the body.
Right. It hops onto the lymphatic highway and travels to the lymph nodes, specifically the ones right there in the neck. It rarely jumps into the blood early on.
Okay, so it stays local, in a way.
It does for a while. Now, compare that to follicular carcinoma. It tends to bypass the lymph nodes entirely and jump straight into the bloodstream. We call that hematogenous spread.
So follicular goes through the blood, papillary goes through the lymph. Why the difference? They were both differentiated, right?
They are, but it comes down to the molecular biology of how the cells invade. Follicular carcinoma has a tendency to invade blood vessels specifically. It's called angial invasion.
I see.
Papillary just doesn't do that as often. It has an affinity for the lymphatic channels.
And what about the other two? The outsider and the villain?
Medullary carcinoma is a bit greedy. It uses both lymphatics and blood. It will go to the neck nodes, but it will also go to the liver or bones.
It's an equal opportunity spreader.
It is. And finally, anaplastic carcinoma, being the aggressive monster it is, uses everything available. Local invasion, directly into the windpipe or muscles, plus distant spread through blood and lymph. It destroys everything in its path.
So if a doctor sees a thyroid issue and notices the lymph nodes in the neck are swollen and involved, their brain should immediately start thinking papillary.
That's the first logical leap, yes. If you see lymph nodes, think papillary. If you see spread to bones or lungs without lymph nodes, you might think follicular. That distinction is vital for everything that follows.
The surgery, the treatment.
Everything, from the type of surgery to the long-term monitoring.
All right, let's leave the villain and the others aside for a moment. We've set the stage. Now I want to focus entirely on the star of the show, papillary thyroid carcinoma. We've established it's the most common, but let's get specific. What exactly are we dealing with here?
Okay. Papillary thyroid carcinoma is a well-differentiated carcinoma arising from those follicular epithelial cells we mentioned. Epidemiologically, it is a giant. It accounts for a massive 70 to 80% of all thyroid cancers.
70 to 80%. That is huge. It essentially is thyroid cancer for most people. And who is getting this? Is this something that only affects older populations? Because usually we think of cancer as a disease of aging.
That's the common wisdom, yeah.
DNA breaking down over time, mistakes accumulating over decades.
Surprisingly, no. And this is one of the things that makes thyroid cancer socially and emotionally distinct. It is actually quite common in young females.
Young females. Any specific age range?
Often in their 30s and 40s, sometimes even younger. And it's about 3 times more common in women than men.
That's a massive disparity. Do we know why? Hormones.
Estrogen likely plays a role, given the gender skew and the age distribution. It peaks during the reproductive years. But the exact mechanism is still being teased out in the labs. But clinically, it makes the diagnosis particularly impactful because you are dealing with people in the prime of their lives, maybe starting families or building careers, and suddenly they are handed a cancer diagnosis.
That is heavy. But there's another risk factor mentioned in our sources that really stood out to me. It felt very Cold War. Radiation.
Yes, this is the strongest environmental link we have. A history of radiation exposure, particularly in childhood, is a known risk factor for developing papillary thyroid carcinoma later in life.
Why in childhood?
The thyroid in children is incredibly sensitive to radiation. It's still developing.
When you say radiation, are we talking about cell phones and microwaves? Or something more serious?
No, we're talking about ionizing radiation. High-energy stuff that can break DNA strands. We saw this historically and tragically after the Chernobyl nuclear disaster in 1986.
Right.
Years later, there was a massive spike in papillary thyroid cancer in children who had been in the fallout zone. Their developing thyroids absorb the radioactive iodine from the air and food supply.
That is a sobering thought. The ghost of a nuclear accident showing up decades later in the cells of children.
Exactly. But it's not just nuclear disasters. Historically, in the mid-20th century, doctors used to treat benign conditions like acne or enlarged tonsils
With radiation.
with radiation therapy. We didn't know better at the time. Those patients saw significantly higher rates of thyroid cancer 20 or 30 years later.
So even today, I guess, children treated for other cancers like Hodgkin's lymphoma with radiation to the neck need to be watched closely.
They absolutely need to be watched closely for thyroid issues down the line. It's a known long-term risk.
So you have a patient, maybe a young woman, maybe someone with that history. Now she has a lump. To get a diagnosis, someone has to look at those cells under a microscope. And I have to say, this part of the research was my favorite.
It's a pathology.
Yes. The descriptions of what these cells look like are, well, they're weirdly poetic. It doesn't sound like science. It sounds like art history.
Pathology often is. You have to remember, before we had genetic sequencing and molecular markers, pathologists were just visual people. They were pattern recognizers. They named things based on what they saw in the world around them. When we look at papillary carcinoma, we are looking for very specific visual markers. First, obviously, is the papillary architecture.
What does that look like?
Imagine microscopic fern fronds, or little finger-like projections. The cells stack up on top of each other to form these little fingers surrounding a central blood vessel.
And that's where the name comes from.
Exactly. That's where the name papillary comes from. Papilla means nipple or nipple-like projection in Latin.
Okay, so the structure is finger-like.
Yeah.
But it gets more granular than that. There are things going on inside the cell nucleus, the brain of the cell, right?
Correct. The nucleus gives us the biggest clues. We look for textural changes. One key feature is nuclear grooves.
Grooves.
Imagine a coffee bean. You know how a coffee bean has that distinct line running down the center?
Sure, I see it now.
That is exactly what the nucleus looks like. It has a longitudinal groove running through it. If you see a cell nucleus that looks like a coffee bean, you start getting very suspicious.
And then there are the Samoma bodies. That sounds like a sci-fi term.
It does, the invasion of the Samoma bodies.
Yeah.
But it's actually geological. Samoma comes from the Greek word for sand. Samoma bodies are essentially microscopic, concentric calcifications. Think of them as tiny pearls or grains of sand forming inside the tumor.
Wait, so the body is making pearls inside the thyroid?
Basically. As the cancer cells at the tip of those finger-like projections die or outgrow their blood supply, they calcify in these layers. It creates a hard, gritty little sphere.
And if you see those?
If you see Sonoma bodies in a thyroid sample, it is a huge red flag, we call it a gold standard indicator, that you are dealing with papillary carcinoma. It is a key exam pearl, pun intended.
Okay, but the one that stuck with me, and I think will stick with the listener forever, is the Orphan Annie eye. I had to double-check the source to make sure this wasn't a joke. Please explain this. Are we talking about the comic strip character?
We absolutely are. It is one of the most famous descriptions in all of pathology. Think about the old comic strip, Little Orphan Annie. How are her eyes drawn?
They were just white circles. No pupils. Just blank, empty white eyes.
Exactly. When you look at the nuclei of these cancer cells under a microscope, they appear empty or clear in the center.
Why?
Normally, a nucleus is dark and speckled because of the chromatin, the DNA packaging. But in papillary carcinoma, the chromatin gets dispersed to the edges, leaving the center clear. They look essentially blank.
Just like the blank white eyes of Little Orphan Annie.
Precisely. We call them Orphan Annie eye nuclei. It sounds funny and maybe a little creepy, but if a pathologist sees those blank eyes staring back at them through the lens, they know they are looking at papillary carcinoma.
That's the diagnosis.
It's an instant diagnosis.
It's amazing how these distinct visual cues, sand bodies, coffee bean grooves, cartoon eyes, are what separate a benign lump from a cancer diagnosis. It feels so analog in the digital world.
It is pattern recognition at its finest. And it saves lives because it allows us to identify the enemy quickly without waiting for expensive genetic tests. You see the eyes, you know the diagnosis.
So we know what it looks like under the microscope.
Yeah.
But let's zoom out to the patient. Let's do some clinical detective work. How does this actually present in real life? Because the thyroid is deep in the neck, you can't exactly see it in the mirror easily.
Not unless it's huge, no.
So how does it present?
That is the tricky part. Often it is completely asymptomatic. The patient feels fine, their hormones are normal, they have energy.
They have no idea.
None. Usually it is found as a solitary thyroid nodule, just a single lump in the gland.
How is it found if they feel fine?
Accidental discovery is incredibly common. Maybe a doctor feels it during a routine physical. Maybe the patient notices it while buttoning a tight shirt or putting on a necklace. Or, increasingly common, they get an MRI or CT scan for something else, like neck pain after a car accident. And the radiologist says, hey, by the way, did you know you have a nodule on your thyroid?
The incidentalloma.
Exactly. But there's a curveball here. We talked about the getaway vehicle. Sometimes the thyroid isn't the first thing that swells up.
Right, because it hops to the lymph nodes first.
Yes. Because papillary carcinoma loves the lymph nodes, patients might present with cervical lymphadenopathy, swollen lymph nodes in the side of the neck before any swelling is noticed in the thyroid itself.
So you could have a lump on the side of your neck, think it's just a cold or an infection, but the real problem is actually in the butterfly gland in the middle.
Exactly. We call that an occult primary. The primary tumor is hidden or occult, but the metastasis is visible. That is a classic presentation.
So the tumor in the thyroid could be tiny.
It might be millimeters wide, but the metastasis in the lymph node is big enough to feel.
That requires a really sharp doctor to connect those dots. A lump in the side of the neck isn't always just an infection. So the patient comes in with a lump. What tools do we have? I assume we aren't just guessing.
Oh, no. We have a very specific workflow. The first look at the neck is almost always an ultrasound.
Okay.
It's non-invasive, no radiation, and gives us a great picture of the anatomy. We look at the nodule. Is it solid? Is it cystic? Does it have those microcalcifications we talked about?
The Sonoma bodies.
Exactly.
But the ultrasound can't tell us for sure if it's cancer, right? It just says something is there.
Correct. It raises suspicion. It tells us which nodules look scary and which look benign. But to confirm, we need cells. We need to see Orphan Annie.
So you have to get a sample.
We do, and the gold standard is FNAC, fine needle aspiration cytology.
It's exactly what it sounds like.
A very thin needle, thinner than a blood draw needle. We insert it into the nodule, usually guided by the ultrasound so we don't miss, and suck out some cells.
Sounds uncomfortable.
A little pressure, maybe, but it takes minutes, can be done in the office, and requires no anesthesia beyond a little local numbing. It's very low risk.
And this is where the diagnosis happens.
Yes. The beauty of FNAC is that it is diagnostic. That means seeing those papillary features, the grooves, the inclusions, the empty nuclei, is enough to confirm the disease.
So you don't necessarily need to cut the patient open and take a chunk of tissue just to get an answer.
You don't. And this is different from follicular carcinoma, where you actually can't diagnose it just by looking at cells. You need to see the edges of the tumor. But for papillary, the cells tell the whole story.
That seems incredibly efficient compared to some other cancers.
Yeah.
What about bigger scans? CTs, MRIs. Everyone always wants an MRI.
They do, but in thyroid cancer, we actually generally reserve those for advanced disease.
When would you use one?
If we think the cancer has invaded deep into the neck, maybe wrapping around the windpipe or the esophagus, or if the lymph nodes are massive, we use a CT or MRI to plan the surgery. But for the vast majority of cases, ultrasound and FNAC are your primary tools. They tell us everything we need to start.
Okay, so we have a diagnosis, we have the cells. Now we have to determine how bad it is. We have to stage the cancer. Usually staging is about how big the tumor is and where it is spread. Stage 4 is bad, stage 1 is good.
Right.
But our source material highlights a really weird paradox here regarding age.
This is one of the most unique and frankly confusing aspects of thyroid cancer staging. In almost every other cancer, lung, breast, colon age is just a demographic detail. It doesn't change the stage.
Okay.
But in papillary thyroid carcinoma, age is a major defining prognostic factor. It is baked into the staging system itself.
Meaning if you are younger, the staging is completely different.
Drastically different. There's a specific cutoff. Currently, that magic number is generally considered to be 55 years old.
55.
If a patient is under 55, the prognosis is statistically excellent, almost regardless of what the tumor is doing.
Wait, explain that. So a 40-year-old and a 70-year-old could have the exact same size tumor spread to the exact same places.
Yes. Let's say they both have a tumor that has spread to the lymph nodes and maybe even has a small spot in the lung.
Okay, that sounds pretty advanced.
It does. The 70-year-old would be considered stage 4, which sounds terrifying. The 40-year-old, with the exact same disease burden, they might still be considered stage 1 or stage 2.
That blows my mind. Why? Are younger cells just better at fighting it?
That's the prevailing theory. Younger patients seem to respond better to treatment, specifically the radioactive iodine we'll talk about later. Their bodies they handle the disease differently. The cancer is less likely to kill them, even if it has spread.
So the staging system reflects that reality.
It does. The staging system predicts mortality, so it has to account for that massive difference.
That is wildly unfair to the older folks, but incredible news for that young female demographic we mentioned earlier. It means even with advanced spread, they have a fighting chance.
A very good chance. It fundamentally changes how we counsel patients. We can look a 30-year-old in the eye and say, even though this is spread, you are going to be okay.
So besides age, what else goes into the staging?
We still look at the classics. Tumor size, which we call T, nodal status, or N for whether it's in the lymph nodes.
Right, T and M.
And M for distant metastasis, meaning has it gone to the lungs or bones. But age is the filter we view all of that through. It's the lens that focuses the picture.
Got it. So we've diagnosed it, we've staged it, now we have to fix it. Management. I assume when you have a cancerous organ, the goal is to get it out.
Eviction notice served. That is the standard. Surgery is the mainstay of treatment. You cannot chemo this away. You have to cut it out.
And we aren't just taking out the lump, right? We're taking the whole factory.
In most cases, yes. The procedure of choice is a total thyroidectomy. We remove the entire thyroid gland.
Why not just take the little nodule out? That seems less invasive. Why remove the healthy part of the gland, too?
It's about risk management. We do a total thyroidectomy for a few reasons. First, papillary carcinoma can be multifocal.
Meaning it can be in multiple places at once.
Yes, there might be microscopic spots of cancer elsewhere in the gland that we can't see yet. It likes to pop up in multiple places like weeds in a garden.
So taking the whole thing removes the seedbed.
Exactly, clean slate. Second, removing the whole gland lowers the risk of recurrence. And third, and this is crucial, it makes monitoring the patient later much easier.
How so?
If there is no thyroid tissue left, there should be no thyroid proteins like thyroglobulin in the blood. If we see those proteins rising later, we know the cancer is back. We lose that marker if we leave half the thyroid in.
That makes sense. It simplifies the future.
Yeah.
But what about those lymph nodes? If the cancer used the getaway vehicle and is sitting in the neck nodes, do you rip those out too?
This is where surgical judgment comes in. If the nodes are clearly involved, if we saw them on ultrasound or felt them, we do what's called a therapeutic dissection.
Therapeutic, so you're treating the known disease.
We are. We clear out the central compartment nodes around the thyroid. We chase the disease and remove it.
But you don't do it just in case.
Generally, no. We call that prophylactic dissection, and it is controversial. The anatomy there is high rent district.
What do you mean?
The nerves that control your voice box, the recurrent laryngeal nerves run right through that area. The glands that control your calcium, the parathyroids, are right there.
So you risk doing a lot of damage.
A lot of collateral damage. So
Yeah.
we don't like to remove lymph nodes just for the sake of it unless we have proof the cancer is there. We treat what we see.
So surgery's done, the thyroid is gone, the bad lymph nodes are gone. But what if you missed a cell? What if there's one little orphan Annie eye hiding somewhere in the neck?
Or maybe it fluted off to the lungs.
Right. This is where the magic bullet comes in.
This is, in my opinion, one of the coolest mechanisms in all of oncology. We have a post-op tool called radioactive iodine ablation.
Ablation basically means destroying, right?
Right. Here is the fascinating biological hook. Thyroid cells are essentially the only cells in the human body that care about iodine.
They need it to make hormones.
Exactly. They have little pumps on their surface that aggressively suck iodine out of the bloodstream.
And the cancer cells, they still have those pumps.
Because papillary carcinoma cells are well differentiated, they still think they are thyroid cells. They still have those pumps. They still crave iodine.
So you feed them a poisoned apple.
That is the perfect analogy. We give the patient a pill or a drink containing radioactive iodine, specifically I-131, that goes into the stomach, into the blood.
And the rest of the body just ignores it.
Every other cell in the body, kidney cells, heart cells, brain cells, ignores it. They don't have the pump. But any remaining thyroid cells, cancerous or healthy, gobble it up.
And then
They absorb the radiation, and it destroys them from the inside out. It cooks them. Since no other cells in the body want the iodine, the rest of the body is largely spared. It is incredibly targeted therapy.
that is brilliant. It's using the cancer's own nature, its own hunger against it.
It is. Papillary carcinoma is radioiodine sensitive, which is a huge advantage for treatment. It allows us to mop up microscopic disease that the surgeon couldn't see or couldn't safely reach.
And then I assume since they don't have a thyroid anymore, they need to take hormones for the rest of their lives.
Yes, lifelong hormone replacement, a little pill every morning. But we do something clever there too. We use thyroxine suppression.
What does that mean?
So the brain sends a signal, TSH, thyroid stimulating hormone, to the thyroid to say grow and make hormone.
Okay.
Even if the thyroid is gone, the brain will send that signal to any lingering cells. We don't want that. So if we give the patient a slightly higher dose of thyroid hormone pill than they strictly need, the brain thinks, oh, we have plenty of hormones.
And it stops sending the growth signal.
It stops sending the grow signal. So you are putting any potential sleeping cancer cells to sleep permanently. You're removing their stimulation.
It's a multi-layered defense. Surgery to remove the bulk,
Yeah.
radioactive cleanup for the stragglers, and then hormonal suppression to keep the beast asleep.
Exactly.
With all of that, let's talk about the bottom line. Prognosis. You mentioned earlier it's excellent, but let's quantify that.
It is excellent. The survival rates for papillary thyroid carcinoma are very high. Depending on the stage and age, we are talking 90 to 98% survival over 20 years.
Wow.
Most patients live a normal lifespan. They die with the disease, not of it.
And this brings us to what I think is the biggest aha moment of this deep dive. We are conditioned to think that if cancer spreads to the lymph nodes, it's game over.
It's the word metastasis. It's terrifying.
Right. And metastasis usually means death is knocking on the door, but you're saying here that's a myth.
It is a massive misconception, often called an exam trap for medical students. In breast cancer or melanoma, lymph node spread significantly worsens the prognosis. It drops the survival rate significantly.
But not here.
In papillary thyroid carcinoma, lymph node metastasis does not significantly worsen the survival rate.
That is so counterintuitive. Why?
It is. It might increase the chance of it coming back locally, what we call recurrence, meaning you might need another surgery down the road to pick out a few more nodes, but it rarely kills the patient. The disease is just that indolent.
Indolent. That's a good word. It's a lazy cancer.
Relatively speaking, yes. It spreads, but it doesn't destroy. It just hangs out. So, listeners should not panic if they hear lymph node involvement in this context. It is very manageable.
We've covered a huge amount of ground here. We've gone from the butterfly gland to the comic strip eyes to the radioactive magic bullet. This is a story of a villain that can be tamed.
It really is.
Before we let our listeners go, let's try to lock this in. We have a 10-point rapid recap to make sure this sticks. I'll tee them up, you knock them down.
Let's do it.
Point number 1. Which type is the boss? The most common one.
Papillary thyroid carcinoma. It's the big one, accounting for roughly 80% of cases.
Point 2. Where does it come from biologically?
It arises from the follicular epithelial cells, the main workers of the gland.
Point 3. Who is the typical patient?
Surprisingly, young females.
Point 4. What's the major historical risk factor we need to ask about?
Radiation exposure, especially in childhood. Think Chernobyl or old medical treatments.
Point 5. How does it travel through the body?
It loves the lymphatic system. It takes the lymph highway, not the blood highway.
Point 6. Because of that, where might it show up first?
Cervical lymph nodes. Look for the lump in the side of the neck, not just the thyroid.
Point 7. How do we know for sure what it is without surgery?
FNAC, fine needle aspiration cytology. It is diagnostic. You see the orphan Annie eyes, you know the answer.
Point 8. Once we know, how do we get rid of it?
Total thyroidectomy is the treatment of choice. Take the whole factory to prevent recurrence.
Point 9. What's the cleanup crew for the microscopic cells?
Radioactive iodine. The cells eat it and die, leaving the rest of the body alone.
And point 10.
Yeah.
What's the outlook for the patient?
Excellent prognosis. Even with spread, life goes on.
I love that. It really takes a scary topic and makes it feel manageable. It puts the care back in healthcare. It reminds us that just because something is called cancer doesn't mean it's invincible.
And that is the final takeaway I want people to sit with. The word carcinoma carries so much fear it feels like a cliff edge. But in medicine, context is everything.
Right.
The type of cancer determines the behavior. In the case of papillary carcinoma, the behavior is indolent, the tools we have are precise, and the correct surgery usually ensures a cure. We have turned what used to be a mystery into a manageable condition.
It's a case where medical knowledge has truly turned a monster into something we can tame. Thank you so much for walking us through this deep dive.
My pleasure. It's a fascinating story to tell.
And to you listening, thanks for being curious. Thanks for diving in with us. We'll see you on the next deep dive.